Thank you, Jaeon, for that nice talk. We will move on to the third topic. Our third speaker will be Dr. Eunha Choi, and she will talk about the clinical experience with COVID-19 pediatric patients. Dr. Choi, please.
Hello, I am Eunha Choi at the Division of Pediatric Infectious Disease in Seoul National University Hospital. It is my pleasure and honor to give a lecture in web seminar about coronavirus disease 2019. My talk title today is Clinical Experience with COVID-19 Pediatric Cases. The published data on COVID-19 focuses primarily on adult and severe disease. So currently, limited data are available on prevalence of COVID-19 in pediatric population because children are less likely to get a test in earlier phase of outbreak. Today, I'm going to talk about the epidemiology and clinical feature of COVID-19 in children, including in neonate, and also talk a little bit about the contribution of transmission. This table illustrates the proportion of children among total cases reported from mainland China, Singapore, Italy, Australia, and Korea. What it tells us is that the proportion of children among total confirmed cases are from 1.4% Italy to 3.6% in Singapore and 5.6% in Australia. In Korea, the proportion of under 20 years old is 6.2%. So the prevalence rate in children is lower than the other age group. So possible explanations for the lower rate in children are because children are less likely to be exposed to the virus due to their limited daily activities, and children also less likely to be tested because of their mild symptoms. The data in this table from more than 2,000 pediatric cases in China shows that more than 90% of pediatric patients experienced either asymptomatic, mild, or moderate disease, meaning that the children have a low percent of critical and severe diseases. While children experience less severe illness than adults, young children, especially infants and neonates, are more vulnerable to this disease. This is the data of more than 4,000 cases from the United States. Mortality was highest in persons aged of 85 years older, ranging from 10% to 27%, and followed by 3 to 11% among persons 65 to 84 years old, and 1% to 3% among persons aged 55 to 64 years, and less than 1% among 20 to 54 years old. However, children less than 20 years old, there are no fatalities and no ICU admission, and also hospitalization rate is much lower than other age group. Let me now switch gears to epidemiology in Korea. This graph shows the cumulative case number of pediatric COVID-19 as of March 11, 2020, according to the pediatric age group analysis by school years. Each age group uses different color code. As you see, children less than 3 years and 7 years were responsible for smaller proportion than other age groups. School children and adolescents account for almost 85%, especially high school adolescents, which is shown as gray, were responsible for 37%. In Korea, we had a first case in a 10-year-old girl whose mother and uncle had been diagnosed with COVID-19. The case was reported on February 18, 2020. What I would like to emphasize in this case is how we practice self-quarantine for children. As shown in this cartoon, the patient lived with her mother, father, and cousin in a multiplex housing unit, and her uncle and aunt lived upstairs. The patient's uncle, which is shown as in black, who ran a store in Wuhan, arrived in Korea on January 20 and had self-quarantine in his room. But during this quarantine, her uncle broke the self-quarantine by having meals in the same dining table with his family members. So her uncle had a diagnosis of COVID-19. And after her uncle's diagnosis, self-quarantine was resumed. So figure on your right showing the self-quarantine after her uncle's diagnosis. Although the patient's father and cousin and aunt stayed in separate rooms, the patient and with the mother shared the same room because of her young age. And later, her mother and this girl confirmed with COVID-19. So this tells us the importance of strict self-quarantine to calming down the virus spread, especially for children. This figure shows the serial viral test results from the multiple specimens of the first pediatric case in Korea. The viral tests were positive in the samples from nasopharynx, throat, and stool. Serum, saliva, and urine tested negative on hospital days 3 and 8. Chest X-ray shows no infiltrate on admission date, and since which was the day 3 since symptom onset. However, chest CT shows the patch nodular infiltrate with peripheral ground glass opacities in subpleural spaces was shown of the right lower lobe of her lung. As mentioned earlier, reports from China describe the clinical manifestation of children with COVID-19 to be mild and asymptomatic infections are common. However, it is difficult to infer about the neonatal infections because neonates have very unique immune systems. So currently only 3 descriptive studies as shown in this table are reported. Fortunately, the infected neonate had mild or no symptoms. There are no evidence of intrauterine infection or vertical transmission. However, neonates are different from children to fight off virus infections in the absence of maternally transmitted antibody. Neonates must rely on their immature innate immune response and also their own immature T cells. So therefore, special precautions including hand hygiene is required for in close contact with newborns. We have a very interesting case pair of 27-day-old baby and her mother. The baby was born by vaginal delivery and directly breastfed from birth from her mother. The baby's father was the COVID-19 case, so the remaining family members had to get a test about coronavirus, and the neonate and her mother, along with her grandparents, are all confirmed with the diagnosis. The baby presented with fever, vomiting, and cough and nasal stuffiness. When you see in this graph is the viral load over time from the days from symptom onset from the neonate diverse clinical specimens. So viral RNA was detected fairly all of different sources of samples, which include nasopharynx, throat, stool, plasma, and saliva and urine. At the early stage, as shown here, the viral load in the nasopharynx was the highest, which is almost 10 to the 10th copies per milliliter, and followed by the oropharyngeal swabs. The viral load in the respiratory samples are decreasing trend over time. So it became negative, undetectable on the day 17. But it's interesting to note this green color. This green color is still a viral load. And the viral load in the stool remains from the beginning and to the end fairly stayed high. So it is very important to note. One thing to add to this slide is about her mother. The viral load of the mother's respiratory and stool specimens was about 100-fold lower than that of the neonate. So this is easy to comparison. This is the baby's viral load, and below is the mother's viral load. So another important finding from this graph is that mother's plasma and urine samples were negative, and also the breast milk was negative for the virus. Let me now introduce another data set that we are currently analyzing. This study included children under 19 years old from Korea, which cases were confirmed from February 18 to March 31st, 2020. This study included children under 19 years of age confirmed with COVID-19 in Korea. All children were placed in hospital isolation or non-hospital isolation unit, so which is very unique. To understand the study results, we have to first figure out how the Korea CDC and local health department respond to this pandemic in this period. So what we did was the KCDC employed rigorous public health interventions, including prompt epidemiologic investigations, contact tracing, and followed by quarantine measures and large-scale testing of all contacts, irrespective of symptom severity or the presence of symptoms. So this strategy is very important, and this strategy enabled us to fully characterize the diverse spectrum of COVID-19 in children. So what we did was to categorize the cases based on the presence of symptoms related to time of diagnosis. So first group is the group who had symptoms before diagnosis. And second group, those who developed the symptoms at the time of diagnosis. And third group is those who had been asymptomatic at the diagnosis and developed the symptoms later. And the last group is the asymptomatic group during the entire period. So it is very important to note 22% was asymptomatic, so no symptoms at all during the entire observation period. And also 51%, more than half, had unrecognized symptoms before diagnosis, and 20% developed the symptoms after diagnosis, meaning that they have pre-symptomatic period, and only 6.6% were diagnosed at the time of their symptom onset. So this suggests that symptom screening fails to identify the majority of COVID-19 cases in children. So transmission of novel coronavirus in children primarily occurs through contact with adult patients, mainly through household exposure. But in contrast, reports on direct transmission from a child to adult is limited. So this cartoon demonstrates from the contact tracing data from Korea of 248 household members who are traced after having contacted with 107 pediatric COVID-19 cases, two index, which is 15-year-old and 16-year-old index children transmit the virus to their family members, resulting secondary attack rate of 0.8%, which is very low. So both cases have infected the family members during their pre-symptomatic period. So one thing to remind is that our data have to be interpreted in the settings of very strict countermeasures of massive scale diagnostic test and quarantine isolation strategy, because transmission rate can be very different by the strategies. So anyway, the data of a low secondary attack rate in Korea underscore the importance of rigorous contact tracing and early isolation in response to the COVID pandemic, limiting the transmission in the household. So one last slide before my conclusion is that the Korean Society of Pediatric Infectious Diseases developed a guideline for COVID-19 response in children. And the Korea CDC actually endorsed this guideline, but unfortunately, it is written in Korean. But we have a good news. UNICEF Seoul office helped to translate this guideline in English, and now it is available. If anybody needs a guideline, then contact UNICEF Seoul's office, then you can get the guideline in English. So in summary, most pediatric cases emerge from family clusters, with most having epidemiology linked to infected family adult members. Clinical manifestation of children with COVID-19 to be mild, and asymptomatic infections are common. Cases of neonatal infection with SARS coronavirus 2 have been reported in China. However, there is currently no evidence of intrauterine infection caused by vertical transmission from mother to child. From an analysis of 91 pediatric cases in Korea, symptom screening misses a large proportion of children with COVID-19. In addition, children are silent carriers of COVID-19, requiring further analysis of the transmission potential of children. With that, I'll stop here and thank you very much.